wanted to discuss just a little bit for people who like pharmacologically the difference between oral delivery and transdermal delivery. Transdermal delivery requires smaller total dose, and it absorbed directly by the skin into the bloodstream, avoiding the first pass of the liver. And it applied once or twice a week versus the oral delivery you have to take every day, and it goes through your liver and basically more inconvenient. And so that's why with time and because of the different studies and because of the modality of how we apply them, transdermal estrogens became more popular. And whether it is FDA approved or not, and because I include in there some of the bioidentical estrogens that are done transdermally that were not approved or recently only approved. And sorry, I had to look up the names of the new just to give you an idea of like what the actual prescriptions for like for example Winona bioidentical hormones was recently FDA approved, and there has been 2 others as well. So there has been a movement away from oral estrogens in favor of transdermal product. Within the category of transdermal product, there has been a rise in popularity of compounded bioidentical estrogen. Medical societies have consistently advised against these products. Although marketed as natural, they are in fact synthesized in laboratory. They are unregulated. The hormones delivered are not consistent. And indeed, there is evidence that bioidentical estrogens products can cause higher chances of endometrial cancer because they don't, include progesterone components often. However, pharmaceutical-grade FDA-approved bioidentical transdermal estradiol is available as patch or gel. It is important to note that transdermal estrogens are exclusively estradiol, while the type of oral preparation available with most data in, for example, CEE, is a mix of estrogen dominated by estrogen sulfate and equivalent sulfate with minimal estradiol content. An example of oral preparation for use in menopause are esteropropyate, esterified estrogens, and estradiol itself. In contrast to estradiol, to some degree, other oral estrogens preparations, the metabolic conversion of the mixed estrogen and the CEE results in the circulation of estrogen with a variety of receptor affinities. In estrogen receptor agonism and antagonism, or selective estrogen receptor modulator-like activity. And that's what makes those different. And that's what makes the outcome as far as the breast or cardiovascular system or anything else different. I mean, these are examples of estrogen approved for menopausal use, whether it is transdermal, oral, vaginal products. And some of them, actually, a couple of them were, I've realized, were discontinued. In general, the contraindication for oral or transdermal estrogen are going to be known or suspected history of breast cancer, known or suspected history of other estrogen-based cancer, active deep vein thrombosis, history of pulmonary embolism, history of blood clotting disorder, most common being factor V, active history of arterial thrombotic diseases, chronic liver diseases, migraines with aura. These contraindications do not necessarily apply to the transvaginal-based estrogen therapy, as the serum concentration for those is extremely low. The North American Menopause Society has recommended that the black box warning that applies to conventional HRG not be applied to transvaginal estrogen treatment. So basically what we know today is that the hormonal therapy formulation, route of administration, and timing of initiation produce different effect. Timing of initiation being the sooner it is, particularly people with premature menopause, we can use them safely. Absolute risk for HT use in healthy women are low, but can induce thrombosis, stroke, and cardiovascular events. The initiation, older women carry greater risk, and breast cancer risk increases with treatment beyond 3 to 5 years. Estrogen therapy can be considered for longer duration for use because it carries a lower risk for breast cancer. So basically, assuming you don't have a uterus. Consider each woman's priorities and risk factor prior to initiating therapies. So, I mean, you counsel those patients accordingly, and you explain to them, and you should, I mean, we should not be afraid of getting into this conversation and prescribing those medications. I think we should be afraid of not prescribing them. As far as alternatives for hormone therapy, I mean, there's a lot of things. There's the fan, the relaxation techniques, really keeping cool, healthy diet. There's a new medication that just came out and was approved in May of this year. It's called Fesolongitin or Vioxxa. Okay, and so that is the medication for hot flashes. Specifically, it's non-hormonal. And of course, non-hormonal prescription drugs like antidepressants, hypnotic, anticonvulsants, antihypertensive, and neuropathic. And of course, there is the alternative medicine, which I'm definitely not an expert in, and carries its own risks. And that's it.